Assisted suicide, a PowerPoint presentation provided by Brittany, Janie, DeTota, and Nicole, Hensley. Assisted suicide. One of the most important public policy debates today surround the issues of euthanasia and assisted suicide. Euthanasia. This is when the provider administers the medication or intervenes in such a way they kill the patient, rather than allowing the patient to take their own life. If the person who performs the act is the patient, it's physician-assisted suicide. If a provider performs the act, it is euthanasia. The patient, an example, the patient pushes a button to interject lethal medication. This is physician-assisted suicide. If the provider pushes the button, this is considered euthanasia. Physician-assisted suicide. A person takes their own life with the assistance of medication prescribed by a healthcare provider. The physician does not administer the medication. The patient does this themselves as a way to die with dignity or with their own wishes in mind. Suicide is not illegal. However, when people commit suicide without the assistance of a physician, the acts are more traumatic on the patient and their families. It is more costly. People have the right to die, and physician-assisted suicide gives them the opportunity to do so without suffering. We have come up with some definitions that we have found, and they are as follow. Voluntary active euthanasia. This is when a physician administers a medication such as a neuromuscular relaxant and sedative to end a patient's life at the mentally competent patient's explicit request. So with voluntary active euthanasia, the patient is mentally competent and they are the one requesting euthanasia. Involuntary active euthanasia. This is when someone is mentally not competent. This patient would request a physician to administer the medication or other interventions to end life. Again, this is non-competent patient request. Non-voluntary active euthanasia. This is when a physician administers a medication or other intervention to intentionally end a patient's life with non-competence. And this patient would not be able to give consent because the patient or the child has Alzheimer's or a condition that compromises decision-making abilities. This would be for like your child who has had excessive seizures to the point where they no longer have brainwave activity, or maybe the patient was in a car wreck, they're brain dead, they're in a coma, or they have Alzheimer's. Or if you guys remember the case of Terry Schiavo, she was actually not able to speak on her own behalf, although her family and her husband had different ideas about what should happen with her. Her husband wanted her to be euthanized, and her parents did not. And so it went to court, and I think eventually she was actually allowed to die, and it was because they removed her NG tube or her maybe her G tube. I'm not really sure on the ramifications there, but I do know that eventually the tube was removed, and removing the tube was the act that allowed her and facilitated her death. So that was non-voluntary active euthanasia. The patient does not have mental decision-making capacity. Now, physician-assisted suicide, it is very different than euthanasia. This is when a physician administers a medication or a prescription to a patient at his or her explicit request with the understanding that the patient intends to use this medication to end his or her life. So, again, the difference is that the distinction is if a third party performs the last act that intentionally causes a patient's death, then euthanasia has occurred. For example, giving a patient a lethal injection or putting a plastic bag over their head to suffocate them, this would be considered euthanasia. On the other hand, if the person who dies performs the last act, assisted suicide has taken place. Thus, it would be assisted suicide if a person intentionally swallows an overdose of drugs that has been provided by a doctor for the purpose of causing death. It would also be assisted suicide if a patient pushes a switch to trigger a fatal injection after a doctor or a nurse has inserted an intravenous needle bearing a lethal drug into the patient's vein. So using these distinctions, we have clarified euthanasia versus patient-assisted suicide. Let's talk about the legalization of physician-assisted suicide and euthanasia. In 1942, Switzerland was the first country to decriminalize assistance in suicide as long as there are no selfish motives by the person assisting, such as obtaining inheritance. The law was interpreted as legal permission to establish organizations to facilitate assisted suicide, including for Swiss non-residents. In 2002, the Netherlands and Belgium legalized euthanasia and physician-assisted suicide. Luxembourg followed in suit in 2009. Euthanasia still remains illegal in the United States. However, in 1997, 5 U.S. states, Oregon, Washington, Montana, Vermont, and California, legalized physician-assisted suicide. Laws against euthanasia and assisted suicide are in place to prevent abuse and to protect people from doctors and others who want to, allow suicide. They are not and never have been to make anyone suffer. But like anything, things can be abused. There are guidelines and safeguards, meaning there are laws that surround assisted suicide. Who has the right to die and at what age? While changes in laws have transformed euthanasia and/or assisted suicide from crimes into medical treatments, in some jurisdictions the reality has not changed. Patients are dying from legal doses of drugs and are prescribed or administered by doctors. Ending one's life is suicide. However, ending the life of another person is homicide. So some of the laws that surround assisted suicide are as follow. In the United States, patients have to be at least 18 years old before euthanasia and physician-assisted suicide is permissible. In the Netherlands, a patient has to be at least 12 years old. In Belgium, they permit anyone, regardless of age, as long as they have the right capacity of mental thinking and discernment, they are allowed to pursue physician-assisted suicide and euthanasia. Basically, in the United States, we require patients receiving physician assistance to have a prognosis of suicide, to have a prognosis for survival of 6 months or less before they can gain physician-assisted suicide. Patients do not have to be in bearable pain. They just basically have to be terminal. And in Belgium and Luxembourg and Netherlands, they require that the patient have an unbearable physical or mental suffering without prospect of improvement, but do not require them to be terminally ill. Belgium does not require that children receiving euthanasia be terminally ill either. Some more guidelines that surround the request for euthanasia and physician-assisted suicide are there is substantial requirements. In the U.S., in order to be permitted PAS, you are required a 15-day period between 2 oral requests and 48-hour waiting period between a final written request and dispensing of the prescription. The Netherlands and Luxembourg do not have a mandatory waiting period. Belgium requires a 1-month waiting period, and Oregon, Washington State, Netherlands, and Belgium require that in the event that someone does choose death with dignity, the law requires them to report the case officially. And 75 cases have been forwarded to the public prosecutor for noncompliance with legal safeguards, but none have been prosecuted. And in Oregon, only one has had been legally prosecuted for not following through with the proper requirements of PAS. What are the public's attitude toward PAS? Support of PAS depends on how questions about PAS are worded when requesting public opinion via survey. Questions asked on public survey usually focus on determining the support of PAS and whether it is acceptable or not. Questions on the public are aimed at determining the legalization or discrimination of PAS, and support of PAS increased from 37% in 1947 to 53% in the early 1970s, and in 2005, 75% of those polls supported PAS. However, in 2012, when the survey was rewritten and the questions were reworded, a dramatic drop in support came about, and we saw that only 64% of those polls supported physician-assisted suicide. So what are the physicians' attitudes toward euthanasia and physician-assisted suicide? Death with dignity laws allow qualified terminally ill adults to voluntarily request and receive a prescription medication to hasten their death. So how many physicians are supportive? In the U.S., 54% of the physicians are supportive. In Germany and the United Kingdom, 74% of the physicians are supportive. In Italy, 42% of the physicians are supportive. And 30% of France's physicians are supported. It's interesting. What are their attitudes? Many physicians consider euthanasia wrong but support physician-assisted suicide. Some physicians think of it as a way of sedation until death occurs. Many physicians wonder whether physician-assisted suicide will eventually lead to euthanasia, meaning, okay, we're allowed to give them this medication or provide them with a means of allowing suicide for them to do it themselves, but hey, let's just push the bar a little further and actually administer the drug or follow through with the termination ourselves. I don't think that that is acceptable. Reporting of euthanasia and physician-assisted suicide is really not concise because not all countries and states are required to report the same. So it was kind of hard to come up with the statistics in regards to reporting. However, we came up with in 2015, it was reported that 218 lethal prescriptions were written by physicians in Oregon. In 2012, 77% of 1,456 physicians reported receiving requests for euthanasia and physician-assisted suicide. In 2012, Dutch pediatricians found that 615 physicians had received requests for euthanasia and physician-assisted suicide, and these included requests from children younger than 18 years of age. What are problems and complications that surround this topic? They are related to the lack of standardization of physician-assisted suicide and euthanasia rules. The rules are not uniform and tend to lead to problems and complications with the process itself. The following items demonstrate a need for standardization for the support and process and reporting of these of euthanasia and PAS. We need to determine the rate of problems and complications of euthanasia and physician-assisted suicide. It's been hard due to the definitions not being extremely clear and a lack of witness. Countries and states, they don't have a law to report. That leaves a gray area on the knowledge of complications and statistics. And then Washington State reported a complication with in which the patient suffered from seizures. So one must ask, is there other issues that do not demonstrate death with dignity? And how might that knowledge impact the support or reform of support on this subject? Meaning, like, if it's death with dignity and they're not supposed to die in pain, why did the person have seizures? Did they suffer? Etc. Ethical arguments are as follow. Does physician-assisted suicide respect a patient's autonomy? Does a patient receiving PAS do so at their own request, or does a doctor encourage them, or does someone encourage them? Patient cannot self-administer pills or lack of decisional capacity or ineligible for PAS. So does this mean it's euthanasia and not PAS? Meaning, like, if the patient is not competent and they're prescribed medication and they swallowed medication, was that homicide or was that actually termination of life at the patient's own request? That is a gray question and a gray matter. Does PAS allow the physician moral distance from the act being performed? Does the physician, if the physician is the one who writes the prescription and allows it to be performed, is there too much involvement there between the physician and the patient? And is permitting PAS without euthanasia discrimination? Why is it justified for some but not others? Pros of physician-assisted suicide. One pro is people have the right to die with dignity and in a humane way. Another is patients have the right to choose their treatment, their body, their treatment, their right to die. Physician-assisted suicide takes away from the guilty feeling of a dying patient of being a burden to the family. Some people don't have the ability to afford medication or terminal illness treatment. Some people don't want to be a burden on their family. Some people are just not wanting to go through with the prognosis of their diagnosis, and they are ready to go on. And with physician-assisted suicide and euthanasia, they have the ability to terminate their life with dignity. Patients sometimes lose their will to live and should be supported through this process. Meaning, if they go off and commit suicide, that's very traumatic for the patient, very traumatic for the family. With the physician-assisted suicide, they can gain support of the family. The family can choose to be there for them. The family doesn't have to find their loved one dead, and it's less costly for society when they choose physician-assisted suicide. Some of the cons is that palliative care can be given to terminally ill patients, and therefore some people are against physician-assisted suicide because some people claim that the reason physician-assisted suicide and euthanasia is ethical is because you're allowing that patient to die with dignity. But some people say, well, they can also die with dignity if they've received palliative care, although palliative care allows the patient to die naturally. So that can go on for not decades, that could go on for a very long time. It's a violation of the Hippocratic Oath, and doctors can make inaccurate prognoses. We know this. Doctors are humans, and therefore they can make mistakes. And not everyone sees it as ethical and moral. That is the case for every topic we can come up with. We know this. Okay. Thank you for hanging in there with us. It was our goal to educate you on euthanasia and physician-assisted suicide. We hope that we were able to enlighten you with the definition of each and how to distinguish one from the other. We have given you some history, we have given you some law, we have given you some statistics, and now we would like to take this opportunity to see if you retained some of our knowledge. Question number 1. What is physician-assisted suicide? A. Physician helping patient prepare for suicide? Or B. Physician-assisted suicide is much different than refusing treatment. Physician-assisted suicide involves a medical doctor who gives a terminally ill patient the means to commit suicide, usually by an overdose or by prescription medication. C. Physician-assisted suicide is when a doctor performs suicide for the patient who is in process of dying. Or D. Physician prescribes sedation medication until end of life occurs. I hope that you chose B, because B is the correct answer. Physician-assisted suicide is much different than refusing treatment. Physician-assisted suicide involves a medical doctor who gives a terminally ill patient the means to commit suicide, usually by an overdose or prescription medication. Question number 2. Is physician-assisted suicide legal? A. Yes, in all 50 states. B. No. Why would it be legal? C. Yes, only outside of the United States. Or D. Physician-assisted suicide is illegal and crime in most states. It's only legal in Oregon, Washington, California, and Vermont. What is your answer? D. Physician-assisted suicide is illegal and a crime in most states. It's only legal in Oregon, Washington State, California, and Vermont. Question number 3. Can doctors be wrong about the diagnosis and prognosis of their patients? A. No. Doctors are never wrong. Or B. Yes. There are many stories of incorrect diagnosis and predictions, as well as numerous cases where people have lived far beyond their doctor's predictions, and some people have been cured from their terminal disease. Or C. Yes, only when it's related to cancer. I hope you chose B, because like I said, doctors are human and therefore they can make mistakes. Yes, there are many stories of incorrect diagnoses and predictions, as well as numerous cases where people have lived far beyond their doctor's predictions, and some people who have been cured from their terminal disease. Question number 4. True or false? You can be 12 years of age in the United States to be able to request PAS or euthanasia. What is the answer? I hope you chose false. You have to be at least 18 years of age to be able to request physician-assisted suicide or euthanasia in the United States, where it is legal in the United States. Question number 5. What states are PAS and euthanasia legal in? Select all that apply. A. Oregon. B. Washington State. C. Tennessee. D. Vermont. Or E. California. You got it. A, B, D, E. Oregon, Washington State, California, and Vermont. I hope you did not choose Tennessee, as we currently do not allow euthanasia or physician-assisted suicide. And that, my friends, wraps up our PowerPoint slide presentation about physician-assisted suicide and euthanasia. Before I let you go, let me do a quick recap. Physician-assisted suicide legally gives a competent patient the right to end his or her own life with the help and guidance of a medical practitioner by the way of prescribing lethal doses of drugs. The time or date of the commission of the act is the sole discretion of the patient. This is not to be mistaken with euthanasia, where the physician will be the one to administer the lethal dose of the medication to the patient. And some of the pros of physician-assisted suicide are the patient would no longer be in pain or suffering. The patient would die knowing it was their own choice. The patient can die with dignity rather than a shell of their former selves. Healthcare costs can be reduced. The nurse or doctor can move on to a patient that has a chance at living instead of spending time helping a terminally ill patient. Pain of the patient's family can be reduced. Vital organs can be saved and used to save other patients. Without physician assistance, patients or people may commit suicide in messy, horrifying, traumatic ways. And finally, one of the pros of assisted suicide is that patients have the right to die. That is their personal decision and their personal right. Some of the cons of physician-assisted suicide are it decreases the value of human life. It violates physicians' Hippocratic oath. Could open the floodgate to non-critical patient suicides and other abuses. Many religions believe if you commit suicide that you are sent to hell. Therefore, it is harder for some families to cope with people who commit suicide, even if it's considered a medical treatment, as we decide that it is considered with physician-assisted suicide and euthanasia. And physicians and families may be promoted to give up on recovery too early. And another con is government and insurance companies may put undue pressure on physicians to avoid heroic measures or recommend PAS as a procedure. So it has been our goal to educate you on physician-assisted suicide and euthanasia. However, before I conclude the PowerPoint, I just want to talk about this situation, or this topic rather, from a nursing standpoint instead of just a research standpoint. I just wanted to let you know that I went to the ANA website, American Nurses Association website, to look at their position on PAS and euthanasia. And basically, the way that the ANA wants nurses to look at suicide, even with the euthanasia and physician-assisted suicide, is that suicide is the act of taking one's own life. In assisted suicide, the means to end a patient's life is provided to the patient, with knowledge of the patient's intention. Unlike euthanasia and assisted suicide, someone makes the means of death available, but does not act as the direct agent of death. Nurses have an opportunity to create an environment where patients feel comfortable to express thoughts, feelings, conflict, and despair. The issue that surrounds a request for assisted suicide should be explored with the patient and as appropriate with family and team members. It is crucial to listen to and acknowledge the patient's expressions of suffering, hopelessness, and sadness. Factors that contribute to such a request should be further assessed and a plan of care initiated to address the patient's physical and emotional needs. Discussion of suicidal thoughts does not increase the risk of suicide and may actually be therapeutic in decreasing the likelihood. The relationship and communication between the nurse and patient can diminish the feelings of isolation and provide the needed support, and allows us to educate the patient. So in other words, the American Nursing Association wants us to address the idea of a patient who wants to commit suicide. They do not want us to encourage it, but they want us to educate on other options. So in conclusion, I just wanted to bring up the nurse's role in this topic, and I hope that this PowerPoint presentation has been enlightening. Thank you and have a great day.